Okay, I would like to welcome all of you, and because one of my jobs is timekeeper, I'm going to have us start on time. I know people will drift in. So my name is Nancy Cass. I'm from Johns Hopkins University, and it is my pleasure to moderate this session under the sort of heading of innovation in global settings. Some of you may know that Primer is doing this initiative essentially this year to highlight some of the posters, which is a really great idea. Sometimes the posters don't get enough visibility. And so this is a plug not only to allow you to see the work of these particular three individuals, but to encourage you after this to go see some of the posters in the conference hall downstairs. So we heard in the plenary this morning some of the challenges in doing research in low and middle income country settings. This panel is going to take on three particular kinds of challenges, but also work to move those challenges forward in that space. We're going to hear about IRBs, we're going to hear about research misconduct, and we're going to hear about informed consent. And one of the things that I really like about what these three panel topics are, in relation to some degree to the big writ large kinds of challenges that were outlined to us this morning, is that to some degree these represent some of the pillars of what we have to do, the foundations in research ethics, right? Research misconduct, the flip side is integrity. If we don't bring integrity to our work and we can't somehow communicate a culture with our colleagues of research integrity, the whole enterprise is sort of dead on arrival. If we don't have review systems that help keep us honest, that guard against our conflicts, and help for the sake of participants make sure that the risks and benefits are reasonable, then consent itself makes no sense, because consent is going with the assumption that somebody else had made sure that the trial is reasonable in terms of risks and benefits itself. And at that point, we need to have a robust and user-friendly, respectful consent process so that people can evaluate whether studies make sense for them. So integrating this with the plenary gives me at least some excitement about this session. So let me tell you who our speakers are. I'm going to introduce everybody right now so that I don't jump up and down in the middle. The first speaker is Marwan Falafel from the American University in Cairo, and he will be presenting results from a survey that he did related to research misconduct and investigators' views in Cairo. He is a senior clinical research associate and leads a team of clinical research associations in Egypt and Saudi Arabia. He has several years of experience himself in clinical research, both laboratory research and clinical trials. And he studied pharmacy as an undergrad student and then received a Master's of Science in biotech. And he's currently in one of the Fogarty-sponsored programs at the University of Maryland, Baltimore. Our second speaker will be Annette Nakaganda from Uganda. She is with the Uganda Cancer Institute and will be talking about establishing the Research Ethics Committee at her institute. So she is a cancer epidemiologist at the Uganda Cancer Institute, where she serves also as the IRB operations manager and research administrator, as well as research ethics instructor. And then our third speaker will be Jerry Pearson from the Office of Clinical Research Policy and Regulatory Operations at NIAID, the National Institute for Allergy and Infectious Diseases, here in the United States at the National Institutes of Health. He will be talking about the development and implementation of graphic aids to assist in the consent process for an Ebola trial with which the NIH was significantly associated this year. Dr. Pearson coordinates with the NIAID Intramural Research Program the support that is required for investigational drug management, clinical safety, IRB administration, and clinical trial monitoring. So I'm going to turn the podium first over to Marwan, and glad you're here.
Good morning, everybody. So today we're talking about the prevalence of research misconduct among investigators in Egypt. This is poster 18 if you're visiting the poster session. I declare no conflict of interest on this activity. Today we're going over the background about research misconduct, our objective from this study, how did we do our study. I'll highlight the important results and correlations we have. I'll also discuss some of our limitations and next steps and conclusions. And of course I'll be available for your questions. So in regards to background, research misconduct, what is it really? In summary, we can say that research misconduct is behaviors or practices that affect the quality, integrity, and reliability of research data, including but not limited to fabrication, falsification, plagiarism, conflict of interest or authorship disputes, failures to follow applicable research regulations. So how big of a problem is it? It's like an iceberg. Sure, it doesn't look that big, but it's just the tip of it. A study by Finelli in 2009 investigated like a systematic review of meta-analysis from 21 surveys, and almost 2% of the responders admitted to have fabricated or falsified data. More than 14% knew about colleagues committing a serious misconduct, and 72% knew about colleagues committing other forms of misconduct. So these data that we have are basically from developed countries, but recently also the Middle East has seen like an increase in the amount of research that we're doing, clinical and bench research. But we don't have that much of robust regulation. They're not keeping pace with the amount of research that is increasing. So the real problem is that the data from low and middle income countries are scarce, especially from the Middle East. So our objective is to bridge this gap. The study aims to determine the prevalence and the attitudes of the investigators regarding research misconduct in Egypt, and we were also trying to determine some of the independent factors that lead to that. So we adopted a survey study from the Scientific Misconduct Questionnaire revised by Broom and colleagues. The survey aimed at collecting demographic information, prevalence of scientific misconduct, acceptability of practices in conduct of research, attitudes of scientific misconduct. So we approach individuals from the American University in Cairo. They included a variety of specialization and degrees. They were undergraduate students, Master of Science students, PhDs, and faculty. The recruitment was done through a link, a web link in SurveyMonkey. We obtained consent from everybody. We collected responses anonymously, and we obtained ethical approval from the IRB of the University of Maryland, Baltimore, and from the American University in Cairo, IRB. We analyzed the data using descriptive analysis and chi-square analysis using SPSS, and a value of 0.05 or less was considered significant. The results were, we had about 191 participants taking the consent. About 95 completed completed the questionnaire, the whole of it. About 2/3 of our participants were females, and 52% had prior research ethics training, and almost 60% had previous research experiences. The participants were in the majority Master of Science students who also had undergraduates, PhDs, and faculty. So in regard to the prevalence, many of the participants reported at least self-reported one or more of the following. and they observed it. I hope you can see this. Conducting human subject research without IRB approval was self-reported by 10.4% and was observed by 21.5%. Making up of research data was also self-reported by 10.4% and observed by 34.6%. Plagiarism, 9.1% self-reported and 43.8% observed. 14.3% have given authorship credit to someone who has not been taking part in the research really, while it was observed by above 33%. Not disclosing a conflict of interest was a little less. It was self-reported by 5.2% and was observed by 13.1%. So this prevalence in comparison to literature was higher than the reported studies involving students in Western universities. However, this prevalence was more or less similar to that reported in Nigerian researchers. In regard to attitudes, 77.3% expressed concerns about the amount of misconduct that is taking place. 50% believe that dishonesty and misrepresentation of data are common. And 64.5% believe that the pressure to publish is one of the major reasons why so much misconduct is taking place. It's also notable that investigators believe that the instance of misconduct should be reported. They believe that the conflicts of interest should be declared, and 67.3% claim that they monitor their trainees to ensure that they become responsible researchers. So we have correlated data to see if research ethics training had any effect on the amount of misconduct that the researchers are getting engaged in. And it was significant that in most of the cases, the results were better with ethics training. We also did correlations to the higher academic degrees in regard to the acceptability of unethical behavior, and it was found that individuals with higher academic degrees are less likely to accept misconduct practices. We could not establish any significant correlation between prevalence of misconduct in regards to gender. The real limitation to this study is that it's based on self-reporting, even though this is anonymous and we're not collecting any personal information identifying information from the participants, but they might still be unwilling to self-report or even record their observations. Results from a single university in Egypt may not be that generalizable to other in Egypt or the Middle East. So the further steps would be that we would like to analyze from other universities in Egypt and other countries in the Middle East to add to these data, and further qualitative research like in-depth interviews should be utilized in order to further explore the reasons why misconduct is taking place. In conclusion, research misconduct is not uncommon in Egypt. The attitudes of the investigators are generally positive, and the situation can be improved by further training. Thank you very much. We'll also be available by the poster number 18 from 1:45 p.m.
Good morning, everybody. It's really a pleasure and great honor to attend this conference, and most especially to have an opportunity of sharing our experience of establishing a research ethics committee at Uganda Cancer Institute. First of all, I would like to let you know that I have no professional, personal, or financial relationship with this activity. And For those of you who may not know, this is a map of Africa, and Uganda is located in East Africa, and as you can see, is a landlocked country. As a matter of introduction, Uganda Cancer Institute is a public tertiary cancer center that delivers specialized cancer treatment to more than 35 million people in East Africa. Of recent, there is an increasing burden of cancer in Uganda, and of course, this is similar to all developing world. The UCI's focus, that is Uganda Cancer Institute's focus, has therefore significantly increased over the past 6 years as many collaborators came on board to identify causes of increasing cancer burden in the region. This actually, the increasing volume of cancer activities at the Institute prompted the establishment of a research ethics committee specialized in the review of cancer research. To my knowledge, this is the first research ethics committee in the region to specifically attend to unique ethical issues inherent in cancer research. And I'm happy to say that the UCI Research Ethics Committee is now functional and accredited, and here I share our experience of establishing this Research Ethics Committee and, of course, recommendations to others. This was a collaborative venture. The UCI Research Ethics Committee was developed by UCI research leadership in regular consultation with regulatory and IRB staff from Fred Hutchinson Cancer Research Center, Seattle, Washington. Establishing the UCI Research Ethics Committee included identifying a local expert to provide guidance in meeting the national requirements for research ethics committees. The process started with developing a work plan and a budget. We started with a well-conceived and rational planning, figuring out what would be involved in establishing a research ethics committee. And this is where we needed to bring on board collaborators with relevant expertise and experience to really guide us in the process. Then we recruited the research ethics committee members, considering different expertise, that is non-scientists and scientists, agenda issues were considered, and community representation. We conducted the trainings with the Research Ethics Committee members, and according to the national guidelines, there must be 2 mandatory trainings, and they are conducted by a national body called Uganda National Council of Science and Technology. 1 training in research ethics, and another training in IRB operations and management. Then we developed the standard operating procedures for the Research Ethics Committee. We got a group of 7 Research Ethics Committee members who developed the draft SOPs, and these were later reviewed by the whole committee. We hired and trained the Research Ethics Committee staff. We started by hiring the administrator, and she took a 4-week placement at an experienced Research Ethics Committee. That was the School of Health Science, IRB, Makerere University. We registered the Research Ethics Committee with the Office of Human Participant Protection and obtaining a federal-wide assurance number. This process was facilitated by colleagues from Fred Hutchinson Cancer Research Center. It is not very familiar to register IRBs and RECs to Office of Human Subject Protection, and many of them really don't have FWA numbers in Uganda. We finally obtained accreditation from the Research Ethics Committee from Uganda National Council for Science and Technology. A formal application for accreditation of the Research Ethics Committee was made, and I don't know, but I uploaded a copy of the Uganda National Guidelines for Research Ethics Committee accreditation for those of you who may be interested in seeing one. I also uploaded the application form. And when you see the guidelines, the process and accreditation of the Research Ethics Committee are on page 3 of those guidelines. In general, it was anticipated that the whole process would take about 12 months, but it actually took 26 months. The most period was spent in meeting the national regulatory body requirements for research ethics committees. We really have achievements. And as I said, an accredited research ethics committee is now in place and functional at Uganda Cancer Institute, and establishing a research ethics committee elevated the function of research and human participant protection at the Institute. And of course, it strengthened our collaboration with Fred Hutchinson Cancer Research Center in regards to research ethics and human participant protection. The process was not very smooth. Of course, there were challenges that I would like to share. One was limited resources to buy equipment and facilitate trainings for new UCI research ethics committee members. Funding came solely from Uganda government, which by the nature of its limited resources and competing interests and priorities was very inadequate and in most cases delayed. This caused competition for shared resources at UCI. The program benefited from hospital resources like physical space for offices, meeting boardroom, computers, stationery, and of course free services of other staff already committed with other responsibilities. Finding time to train very busy UCI Research Ethics Committee members was also a challenge. Uganda, and most especially at Uganda Cancer Institute, there is lack of human resource. For example, we have very few, actually, about 5 oncologists in the whole country. These ones are the ones involved in teaching at the university medical school. They are the ones providing medical care. They are the ones involved in research, and they are the leaders and managers of this institute. So you can imagine how long and how hard it was for us to secure time for their training. Due to limited time and funding, there was inadequate training of these members in issues surrounding oncology research. The available funding could not allow for more training other than the 2 mandatory trainings required by the national regulatory body. And we are trying to apply for grants to support these continuous trainings of the Research Ethics Committee members, most especially on ethical concepts and principles and in issues in relation to local culture and norms. Of course, delays in the project plan was a big challenge beyond what was initially anticipated. As said, this was mainly in meeting the national requirements for obtaining accreditation. It actually took a whole year after the Research Ethics Committee members were trained to start reviewing protocols. We learned the lessons, and I would like to share some recommendations for research ethics committees, especially in resource-constrained settings. One is that consultation with local and international collaborators provided an in-depth understanding of the Research Ethics Committee establishment process. Central accreditation by Uganda National Council for Science and Technology ensured high standards of the REC. And I would like to recommend sensitization of government officials, especially for public institutions, about the role of research ethics committees and human participant protection. We realize that establishing and running a research ethics committee is very expensive, yet we had no operating budget line. And for this purpose, we recommend that research ethics committees be allocated their own funding and a budget line and vote different from the existing financial arrangements of public institutions. The process and timelines of establishing a research ethics committee, we also recommend that it is explicitly set out in national guidelines. It took us some time to figure out what was involved in setting up a research ethics committee. And it would be helpful if it was stipulated somewhere, somehow, especially for the developing world. This is one of the reasons that motivated us to document our experience for others who may be interested in establishing a research ethics committee. I would like to thank Dr. Rem Jackson, the Director of Uganda Cancer Institute, and Joyce Kambugu, the Head of Research Directorate. My gratitude goes to Ms. Rachel McLennan and Karen Hansen of Fred Hutchinson Cancer Research Center for their support in establishing a research ethics committee, and of course, Mr. Julius Sekuru of the Uganda National Council of Science and Technology. Lastly but not the least, I would like to thank Mr. Poku Tyabami, the chairperson, and Stella Alport, the administrator of the School of Health Science IRB, to really train and orient the IRB staff for the research for Uganda Cancer Institute Research Ethics Committee. And I would like to thank you all for listening to me.
Good morning, and thank you for the opportunity to expound a little bit on our poster that Tracy Miller, Stacy Kopka, and Sarah Albert helped put together. Thank you. So, I have no relevant conflicts, and as with any sort of presentation from somebody working in the government, anything I say is my own personal opinion and doesn't reflect upon the Department of Health and Human Services. So to get started, with regard to what we're going to talk about, I'm going to put things into context, because with regard to getting to the point where we're actually able to implement our protocol and actually have our consent process, there's a lot of background to go through. And the first of all is to talk about a little bit about the organizational context in which things exist. So within the NIAID itself, of course, most folks know that within the NIH, there's 27 centers and institutes, more centers and institutes to talk about than you can put on one slide. Within the NIAID itself, I work in what's called the Division of Clinical Research, and most of you who get NIAID funding, it's from one of the extramural divisions. That would either be the DAIDS, the DMID, or DATE. The Division of Clinical Research exists primarily to support our intramural research program, but also to do what the NIAID director would call special projects. And within the context of special projects is where the Ebola clinical research response took place. With regard to the Ebola outbreak, it's important to have an understanding of how the various response took place. This is a map put together by the CDC depicting the outbreak itself and the various activities that CDC put in place to respond to the outbreak. And as you can see, the best portion of the epidemic took place between July and then through March was when the disease was at its worst. With regard to getting a clinical research response in place, one of the things to keep in mind is that the clinical research itself was a difficult undertaking within the context of a relatively difficult to control public health emergency. So one of the things that was important was that we had to have a true invitation from one of the governments within West Africa to take part in the clinical research response, because doing clinical research is very different from the standard public health response that's required to address a disease outbreak. So the other part that's very critical to understand is within this public health outbreak, there really were no good options immediately available to respond with regard to drugs and vaccines. In fact, the phase 1 trials of the candidate vaccines that were eventually used weren't even started until September 2014. So very late in August, the government of Liberia did send a request for a research response. Early October, we were able to actually conduct a visit into Liberia to address what that research response would look like. There were a series of meetings over November and December and January, and we were finally able to get our research off the ground early in February. The most important thing about doing that research program, though, was the initial meeting that took place in a very small context between my boss, Dr. Cliff Lane, and the Ministry of Health within Liberia. And it was not about what kind of research we were going to do, but establishing the principles of the kind of research that we were going to do. And those principles were relatively straightforward, but unbelievably important within the context of being able to provide a framework for which everything else fell into place. And it was basically, as stated there, that we had to have priorities that fit within the needs of Liberia, the context of the kind of research that could be done, the commitment that would be required upon all partners, and the fact that we needed to look at what was available to help us actually launch that research within the environment in which we were doing the research. As we discussed through the months of October and November, we actually had to have a framework in which to do that research, and having that framework of governance, executive committee, and some operations teams were critical to putting in place that research enterprise on the fly, because within this environment, things were happening very fast, and various lessons learned from other endeavors that Dr. Lane had taken part in were critical to working with our Liberian partners. And the most important thing that I think happened with Dr. Lane was that his capacity to listen to input from the Liberians and to adapt various structures that would meet their needs were also critical. So we put all of this into place. So within the context of listening to the Liberians, we came up with a study design that was a randomized placebo-controlled trial. One of the things that was interesting is that when discussing the trial design with the Liberians, there were various discussions about having an active control, not so much a comparator, but just some sort of active control vaccine. And our Liberian colleagues were the ones who actually recommended that we just go with a placebo control because it provided a pathway to answering a research question in the shortest amount of time. A little bit about our study design, for which you can read that yourself. So our initial clinical trial design was to do a phase 2 study to be immediately followed by a phase 3 trial. The phase 2 trial was to involve 1,500 participants closely monitored by a DSMB, and then move on into a phase 3 study. As it turned out, because of the effectiveness of the various public health programs done in Liberia, the epidemic, by the time we were done with the phase 2 portion of the study, had sufficiently waned that it was going to be impractical to move on to the phase 3, and it was recommended that we just stop there at the end of the phase 2 portion. A little bit about the eligibility criteria. It's interesting, this third criteria, likely to be in the surrounding area of the vaccination center for at least 1 year, was put into place because there are a number of various people who wanted to be part of the study who weren't necessarily going to be around to actually evaluate the various healthcare responders. And we were like, this needs to be something where we can actually follow the individuals within the context of the research environment. Considerations in the consent process. So within the context of doing research in Liberia, it was became quickly evident that the context was very much a verbal, oral tradition type communication process, a relatively high literacy rate, but in terms of the variability in understanding the written world, it was written word. It was there's a high degree of variability. A lot of misconceptions about Ebola. There was So we think about things flying around our internet here with regard to various conspiracies, things, the oral traditions going on in Liberia about misconceptions about Ebola were unbelievable. And then the issue of trying to explain placebo and randomization was a concern about how we would do things with this trial. So in typical research response, you would try to spend a considerable amount of time working with the community and the community engagement process to understand best how to do things. And within the context of this relatively quickly moving emergency research response, we had to work within the structures that were available to us to try to identify as quickly as possible how to get things done. So we worked within the context of the Liberian Incident Management System, which is described below, but the most important portion of that was the social mobilization team. And they provided us the best feedback that we could possibly get within the short period of time that we had available to develop that response. So the concepts that we were most concerned about as we developed our graphic consent was just how to go about doing voluntary participation, and the context of this being a continuous process, that somebody didn't have to answer the question immediately. We really wanted participants to have a dialogue within their communities, with not just with the researchers. The concept of randomization was going to be something that we thought was going to be fairly challenging to communicate, and we talked about various gambling type things, and one of the things that our Liberian colleagues explained to us was to use this concept called cocoa mise, and which was very well understood amongst our Liberian colleagues. A placebo and what to call the placebo, and they just said just call it salt water, worked out quite well. And then the follow-up period and the importance that we're going to have to follow people for a substantial period of time, and how we would be following them up were key concepts. So within the area where we conducted the research, if you look at this hospital, this is Redemption, where our vaccine study was taking place. The use of graphic aids is widespread in this part of Africa, and there are a number of different graphic concepts already displayed on the side of the hospital. Individuals were brought into an information session where each person had their own flip book, and as well as the things on the wall where a member of the team would explain the process to them. They'd go home, and then they'd come back for an individual consent process also. There were rooms off to the side of that building. They had vaccine administration. We had very good compliance. And then we actually have a fairly good program of future research that's going to take part after this study. So one of the important things here is that within the context of a quickly evolving scenario, we've been able to take a look at helping out in Liberia with their physical infrastructure and their research capacity. A number of acknowledgements. We can't say enough about the learning to work with the Liberians, and I think that for the most part, we have grown and benefited more so than the Liberians, because it's been a great partnership. Thank you.
Great. So thank you to all of you for a terrific set of presentations and for sticking to the time, which means that we have a little more than 20 minutes for questions. So just come to the mics if you have a question, and if I could request that you state your name and your affiliation before you ask the question, that would be really helpful. Yes, please.
Hello, Natalie Klein from the U.S. Army Medical Research and Material Command. Wonderful set of talks. I wondered whether any of the panelists could share some insights on communicating secondary uses of biospecimens collected in different regions of the world, I'm thinking of the VSV study, but also maybe our speaker from Uganda could speak to those issues abroad.
If I got you right, do you mean storage of samples for other research purposes other than the one they are consenting to participate in?
Yes, both the storage for future uses and also maybe the sending of those specimens to other countries for analysis.
Yeah, in Uganda, it is the consent for sample storage and other use of, other than the study they are participating in, is a separate consent form. According to the Uganda National Council of Science and Technology guidelines, it is not acceptable to put just a paragraph in the main consent form requesting for the participant to just tick. And actually studies who have done that, they virtually have no consent form for future sample storage and use for other studies. The different consent form for sample storage, the contents are well stipulated in the national guidelines, and it involves you explaining very well to the participant what are you storing, how are you storing it, where, who is the primary responsible person in the country for those samples. If at one time they change their mind, how will they know that actually the sample is going to be destroyed? And this happened to one of the research studies I was involved in recently. A participant changed a religion to become a Jehovah, and she came and requested, it was a study that recruited her and all her children. She requested all her samples to be destroyed, and she doesn't want to be involved in any other studies that take off blood. So we did that. So because of those cultural issues to do with samples and tissues, we have a separate consent form. It takes about 5 to 6 pages in my experience.
So that's a very good question with regard to the future use of samples, because one of the reasons that the NIH has invested in the development of the Liberian Institute of Biomedical Research is to have the capacity within Liberia to do future biomedical research to the extent possible. Now, one of the things that did get worked out in early discussions with the government of Liberia was the need to actually export a portion of some of the samples for some of the assays that would have to be done for validation purposes. The immune assays that are available right now for the establishing the effectiveness of the vaccines that were being used aren't fully validated. Those initial tests were done in Liberia, but if we're going to be looking at the effectiveness of those vaccines down the road, they'll have to be done in a laboratory that is fully validated, and that right now doesn't exist. But at some point, some of those samples may be exported, but that was explained within the initial consent. But for future research, that would be taken back to what's called the National Research Ethics Board within Liberia for consideration, and they would make the determination whether or not they'd have to go back and explain any future research to those participants.
Thanks.
Thanks.
Karen Beckman from the University of Oklahoma. This is to the first speaker. Do you have any insight into why the self-reported incidence of scientific misconduct was higher than what's been reported in the West? Are the investigators, is it harder to publish? Are they more dependent on grants to provide their salary? And do you have any thoughts of why that disparity was seen?
Well, I think it's basically related to the lack of robust regulations. Things like that could go without consequences, pretty much. So that's one thing. What you have mentioned in regards to being dependent on the grants or with the pressure to publish or other routine or bureaucratic things they have to go through could be a reason why they could engage in something like this. But as I said, it's one of our further steps is to do an in-depth qualitative studies to further assess that. Thank you.
Yes, please.
Hi, my question is for Ms. Nakaganda. My name is Martha Alvarado. I'm an IRB administrator at Mount Sinai Beth Israel in New York. Given that you've established your office, can you, or do you have information on the volume of proposals that have come in maybe every year and the amount of proposals, given the breadth of the UCI and how many people you serve? What kind of workload is your board reviewing?
Oh, thank you. That's a good question. I've not taken real counting, but we specifically review cancer research protocols, and currently we have about 70 research projects running in the country and at the Uganda Cancer Institute. Yeah, excluding students' research and everything.
Hi, I'm Paula Knudsen from the University of Texas in Houston, and I congratulate you on your projects. I was depressed by the experience in Cairo, heartened by the experience in Uganda, and confused about how you had the courage to do a clinical trial in the midst of an Ebola outbreak. And what do you think people really understood? I keep thinking about the therapeutic misconception. And when you were doing the consent process, I'm sure you tried very hard, but people in the midst of a community undergoing such a severe outbreak must have hoped you were going to keep them from ever getting the disease. And how did you deal with that?
You know, that's a very good question. I think that the concept of therapeutic misconception is one that doesn't really matter upon what research environment you're working in. It's something that's universal. And within the group that we were working at, there were a number of ways that we communicated with the community. Prior to the actual kickoff of the study, there were town hall meetings in the area where the study was to be done to explain the study, to explain the concept that what we were doing was a research study, to talk about the fact that we didn't know that our vaccines worked, and there were the number of ways in which it was communicated were absolutely astounding. One of the groups that helped us in our social mobilization process actually even used music. They put things to music and actually had various performances done. And in the one-on-one sessions with the various research participants when they came through, you know, in terms of measuring that, it would be an interesting thing to look at after the fact. There were a number of things that went through my head in particular as we got closer to getting the study off the ground. Wouldn't it be nice to do this? Wouldn't it be nice to do that? But given the time frame in which things were happening, it was just a bit too challenging or daunting to try to put anything in place. But no, it's impossible to know that what people really thought in terms of the level of protection.
Well, you are doing follow-up. Could I suggest that you ask them at the first year, did they really understand, or have them tell you precisely what they understood, and see how well maybe you could measure it that way?
That would be one way to do it. We also have an opportunity with the future vaccine study that we're looking at putting into place, and those would both be good questions, good opportunities in which to answer that question.
Thank you.
Thank you.
So I'll take the moderator's prerogative right now, since there's no one else waiting to maybe ask a follow-up question on Paula's question to you, Jerry, which is I'm going to look at it from the other side and pick up on something you said about doing research is very different from the standard public health response. And there's no question that on its face that is absolutely true. Some might also argue that research could be an essential piece of a public health response to a very threatening epidemic. And I just wanted to know your thoughts about that, sort of where our commitments are with regard to both public health containment and traditional research ethics, and where that fits when you do something like the PREVAIL study.
So that's a very good question, and one where I'm going to have to actually say that, of course, these are my opinions, and I can't speak on behalf of the government, but this is something that is something where our own organization is trying to establish for lack of a better term, an emergency response element. We don't have it right now, but it really requires having an infrastructure available to launch at the time that, or shortly after, there's a larger surveillance response that goes out with regard to whatever's going on. So it's a challenging thing to be able to do. And we hope that within the next year or two that we'll have that kind of capacity to be able to have a team available to go out on various emergencies, and moreover to have, there is within the government an initiative to put in place what's called a Public Health Emergency Research Review Board, to be able to review that research in a timely fashion, and then to actually have, and this is somewhat trite to say, but some protocols, some template protocols that research review board could have looked at, and then to, so that at least there's concepts that are pre-reviewed but not pre-approved.
Right.
It's a very important, and then to fill in the blanks on the template. But one of the things that, when it comes to public health emergencies, regardless of how much work we do to put something into place, nature finds a way to just make things more difficult than what you think you're going to plan for.
Yeah.
I'm Art Anderson. I'm the IRB chair, former IRB chair, but director of the Office of Human Use and Ethics at the U.S. Army Medical Research Institute of Infectious Diseases. Some of the products that are being discussed here actually were the scientific basis were developed at our institute and by investigators formerly from the institute. When you were talking about the difference between the public health response and doing research, the same relative time frames based on media reports, that when they realized there was lack of cooperation in different villages to the public health requirements for quarantine and for safe habits and so on to prevent the outbreak of Ebola. Some teams went out to villages to help to train the village how to prepare for the possibility of an outbreak. And one of the teams went to a village, and because of fear, even while they were trying to communicate, they were hacked to death because of the fear generated by the epidemic. And so in that context, I can understand how it would be difficult to couch a research project in a public health environment, since the public health individuals were being endangered. The other thing is that there is another approach to this, which was actually exercised with regard to identifying Ebola in the region, in that USAMRIID scientists from our Diagnostic Systems Division had been in a Lassa fever laboratory since 2006, studying their preliminary various chain reaction diagnostics against various infectious diseases. And early in the epidemic, they volunteered their time to directly identify cases of Ebola. And so they had already established in Liberia a trust network. But in the other countries, there was no basis to trust scientists coming on the ground. I'm sure you must have felt some resistance to going in there and not necessarily in Liberia, but in other areas to do this type of study. Did you find that to be true?
We found a lot of things across the spectrum. I would say that we had feedback, positive feedback. We had some negative feedback. It's too bad I didn't keep a diary.
Yeah, I'm sure that's true. So let me throw out another question, if I may, and this time for Marwan. I know we were all interested in your survey and the rates of reported misconduct. I was wondering if you had collected any further information. I know you plan to do even more work here, but if you had on the survey collected information about the different types of misconduct. Needless to say, any kind of misconduct is bad, but there are arguably some things that might be considered even more egregious than others, and it would be interesting to know within the self-reported statistics that you shared with us, if you have any more information about some of the specifics about what was going on or which practices are most prevalent in that community.
Okay, the practices that were more common than the others were instances of plagiarism and falsification more than the others. The least reported were related to conflict of interest. I do not have specific reasons why these in particular were higher than the others, but people who have received ethics training were asked several questions related to whether these trainings included, whether these trainings have included specific things on research misconduct or not, and some of them would have answers such as we don't remember or yes or no. So it's a good pilot to see where to go later on. That's what I think it is at the moment.
Yeah, absolutely. And I will say, as myself, someone involved in ethics training, both of people from the United States and outside, it's rare that we get data as crisp as yours about the impact of ethics training. So I encourage you to publish it, and everybody's going to be citing it. It's great to have that out there. So thank you for doing the work. Please.
Yes, thank you. My name is Latifa Adelmouch, and I am from Morocco. I'm working in epidemiologist, and also I am working as a teacher, teaching at the medical school, and I am an IRB member. So my question is for Marwan. I congratulate you for your study. It's quite interesting. And my question was about, have you done any analysis, subgroup analysis? I mean, for position, like for, you had PhD students, you had undergrad students, you had faculty members. So I think that you might find differences of distribution of misconduct, prevalence of misconduct, according to position. So I don't know if you have already done this or you are planning.
Yes, I think I mentioned something about this in the presentation, that individuals who hold higher degrees show less likability to engage in misconduct. So, for example, PhD students that reported misconduct, either self or observed, were were less than those who only had a master's degree, were less than only those who were undergraduates or have a bachelor's degree only.
Okay, thank you.
Thank you.
All right, so I'll do my last moderator's prerogative and just ask a question for Annette, which is, in my view, we find ourselves at a really interesting time in the evolution of creating new IRBs, or research ethics committees, in that on the one hand, there are many institutions now throughout the world, many countries throughout the world that have already gone through the process of creating a committee, and at the same time, there are many, many institutions that haven't and plan to start. So there are some resources, but there are so many places that are still about to embark on that journey. And I'm wondering if you have advice for them. So you've just done it so that they don't have to completely invent a new wheel. What advice would you have for a colleague who is about to start the same journey?
I think the general advice I gave is more to do with collaboratively establishing research ethics committees, because this addresses the global research phenomena. The way to go is to even conduct collaborative research. So it's better to know the expectations of all stakeholders when it comes to institutional review boards, what they expect, and so on before you put up one. Two, it should be a bit a systematic process. When we got the accreditation comments, the national body indicated that actually our IRB has the highest standards. I think because we really planned it and we knew what to do first and what to do last. We asked our colleagues who had established long ago, it's like, oh, the guidelines were not so familiar. We just got a group of people and started reviewing protocols. And then SOPs followed later and later and later. So I think it should be a systematic, planned project, because it is important, should be done, and knowing which budget line to get funds for that research ethics committee. Because it's a bit expensive and sometimes it's not a business, you might not get profits or returns. Thank you.
Thank you. All right, so I think then we could probably close this session a little bit early. Reminder to all of you to please complete the online evaluations at the end of each day, and help me thank our panelists for great presentations.